I used to hitchhike down to London and go to gigs underage. I think music, going out, but also this underlying concern of social justice and injustice and equality have been quite important driving forces for me. My first degree was in history, I should say. My second degree was in gender studies. My third degree was social policy, interdisciplinary, but looking at gender and nightlife. And one of the things I was particularly interested in was the gendering of pubs and clubs in relation to alcohol. And when I was doing the research on that in the early 1990s, late 80s, early 90s, looking at the gendering of pubs and clubs, it was really the story about why women weren't going to pubs and why they felt alienated or marginalised in them. And I'd spent a lot of time myself working as a barmaid in Birmingham clubs, and so I was interested in the dynamics around gender. And this idea from Victorian times that in the UK, British pubs were male spaces. They were the place that working class men went to get away from the home, the wife, the kids, all of those sorts of things. It was really the exclusion of women from nightlife that interested me, but also the gender dynamics around alcohol. And then in the early 1990s, when I was looking at that, there was this intriguing phenomenon. I'd moved to Manchester and was doing research around Manchester, where suddenly people would talk to me and say, yes, I go out to pubs, go drinking on Friday night. On Saturday, I don't drink any alcohol and I go to raves. So there's this big question mark about this, I guess, big social change at the time that I was not particularly aware of until I was drawn into it by the people that I was interviewing. And they were saying, hey, there's something quite different going on here. And when I looked at people's alcohol consumption, and it was 0 on a Saturday night, I thought, well, this is fascinating. So I ended up going along and doing some of the first research in raves with a guy who's dead now called Russell Newcomb, and he set up the very first rave research bureau, that he called it, and we went into raves and we looked at people taking illegal drugs, but also the dynamics around violence. And you see, the other thing that was really interesting for me was pubs and clubs were traditionally associated with men getting drunk, harassing women, punching each other, things like that. And then when I went to raves and talked to people there was almost no violence. People were taking this new drug called ecstasy, were very friendly, welcoming to strangers, but there wasn't the sense of the sexual intimidation or harassment of women, but also the violence and aggression towards other men. So it was sort of a safe space for young people of both genders. And so that intrigued me as well. And so we started looking at that and found that really the only problems from a sort of crime perspective, from a disorder perspective, related to dealing. So the problem was that the drugs were illegal. And when I spoke to police and security, they would say, well, actually, there's very little disorder. There's very few people to arrest at raves apart from dealers. So I guess I got drawn into drugs research by people who were taking drugs and were not drinking alcohol. So that was how it happened, really. So I wasn't seeking out to do drugs research at all. But going back to education, I'm the first in my family to go to university. I got a place to do history at Cambridge. And I had a great tutor who taught me on the history of crime and deviance. And I guess one of the takeaway messages for me from that in relation to the history of crime and deviance was that it's historically context-specific, it's culturally context-specific, what we see as acceptable behaviour or unacceptable behaviour, what we classify as deviant or criminal. And that changes, so that was one of the things that interested me, how different societies see different drugs as acceptable or unacceptable for all sorts of reasons, taking drugs for spiritual reasons, religious reasons, medicinal reasons. It was intriguing because it was this new drug. People would go and take this one little white round pill, as they were then, dance all night, not be interested in alcohol. And many of the raves didn't sell alcohol. People were not interested in that at all. The Ministry of Sound, I don't think they got an alcohol licence until about 1996. Bowlers, the big rave in Manchester, didn't get an alcohol licence until 1998. And even then, when they did get alcohol licences, the regulars there were not happy about it because they thought it would bring in the wrong people and they associated it with bringing in trouble. There was a mystery around these little white pills and what they did. And I think at first a view that they were generally benign. People were dancing, not causing trouble, not fighting. Slight concern around vulnerabilities for women and an idea which we see going back 100 years of the idea that other people ply drugs to women to take advantage of them. And so you saw some of that coming through in the media. But generally, I think at the beginning, the coverage was fairly benign. But then people started to die in clubs in the 1990s. People didn't really know why. And there was a toxicologist at Paddington Hospital in London called John Henry, who's dead now. And he looked into that. And he was the first person who really identified that there was actually an issue with MDMA itself, and that if you take enough of it, you can overheat, overdose, and potentially die. And that was the first time that people started to realise that the idea of dehydration, overheating, could itself be a problem. And I think before then, the view was that if there were any problems, it was because of something being missold as MDMA, not MDMA itself. So in the mid-1990s, the message was to drink as much water as you can, chill out. All the harm reduction messages were around that. Clubs were told not to turn off the tap water in the toilet so that people could hydrate, having chill out spaces. So there were all those sorts of messages. And then Leah Betts died in the mid-1990s. And I guess that was the first poster girl for an MDMA death. And she only took one tablet, she had one dose of MDMA. But because she'd listened to all the messages about stay hydrated, she drank too much water. She drank, I think, about 7 litres in an hour. And she died from too much water. And that was the first time that had really come to people's attention, the idea that you could drink too much as well as too little. And so harm reduction messages had to really recalibrate then. And I think along with that, pills started to vary in their strength more and more by the late 90s. And I'm old enough to have been doing research throughout those decades. And by the late 1990s and 2000s, we saw the strength of pills declined enough that people would start to take 2, 3, 4, 5 on the dance floor, much more variable. We see the death rate increase from just a handful that we start to see it get to over 10. And the other concerns then were about adulteration as well. We start to see tablets being missold as MDMA for various reasons, including the scarcity of the precursor ingredients. So we have this sort of combination really of factors of the market changing globally and also changing patterns of behaviour in the UK. We see cocaine, more people drinking alcohol, so we see polydrug use and the complications of that. But along with that, this fluctuation in the strength and pills increasingly starting to be seen as not simply one round pill of one dose, but because of that variation in the strength and the less reliability of it, is that we moved to MDMA crystal. And there was a real concern then with the shift from tablets to crystal of overdosing, because instead of just taking one tablet, people were taking unknown amounts of pure crystal MDMA, and the death rate still increased further in the 2010s because of that. And we get to sort of the peak level of deaths in 2018 or so, where over 90 people died from MDMA overdose. And that's from taking MDMA, from MDMA-related complications. Well, so it wasn't my idea. Drug checking's been happening in Europe since the late 1980s. In the Netherlands, they led the way. They've got a fantastic national network of drug checking services. And for me as an academic, I would go to international conferences and hear what was happening in Europe. And when I came back to the UK, people would say, oh, there's no way that that's going to happen in the UK. It's a great idea. It happens in Europe. It's not going to happen in Britain. We've needed change in the law. And so I was sort of, interested in that, why there was this idea that it's something that's great that happens in Europe, but it's not for the UK. And then I was doing research in festivals from 2010, doing annual surveys, which we still do, of festival drug use. And I would talk to the police, security, festival management about what was happening in Europe. And they said, oh, that's interesting. And so I saw a little glimmer of possibility and opportunity there. And I think probably I'm a contrary person by nature. And so I was sort of pushing a little bit on the door, which was not at all open, but I could see like a glimmer of light coming through, and saying, well, maybe we should try this in festivals. Maybe we can have a pilot in festivals. And I think one of the things which is possible at festivals is there's an opportunity to try things differently. And I think there's a few reasons for that. Firstly, with drugs festivals have higher levels of drug use in everyday life. drug users take more drugs at festivals than in everyday life. They'll take larger quantities and they will take larger ranges of drugs, and they'll take them for longer hours. At a festival, it's okay to have lager for breakfast and weed for lunch and MDMA in the early afternoon, and it's all the normal rules of everyday life are sort of suspended for a little bit, and that includes in relation to drugs. People are away from all of the responsibilities of work, home, family, and so on. So when I posited this idea of, hey, let's have a pilot at festivals, is the festivals were open to it, the police were open to it, because I think it's just, it's only 3 or 4 days in a field. Let's try it. And also at nightclubs as well, where I was doing research, having that same conversation with nightclubs, that why might we just try it for one night and find out what's in circulation. And I think the important thing there is we have an illegal drug market, so nobody knows what's in circulation, and everybody wants to know. Police want to know, public health want to know, people taking the drugs want to know, even the street level dealers want to know, and they probably don't know either. So we all want to know what's in circulation, but I was interested in seeing what can we do that's within the law. So I was framing it, saying how far can we go with this within the law? What can we set up? And that was really how it started. And the other thing to say is that there was a lot of support from, I got pro bono support from a barrister that I knew. It was fantastic. Support from the police. And I think that helped being a criminologist. But also I think I was at that point a government drugs advisor, sitting on the advisory council on the misuse of drugs and talking to people who are already testing on site. And so I have to shout out to Tic Tac, which is an organisation that was already testing the things which are seized on the doors at clubs. So they had started testing things that were seized on the door at Fabric and various Vauxhall nightclubs. And so I also thought, well, if they're doing that for intelligence purposes for the police, I can do that for harm reduction purposes, fingers crossed. So the first nightclub that we were testing for harm reduction purposes was in Manchester, and that was the Warehouse Project, and we still do tests periodically there. And what we were doing was something called back-of-house testing, where we would get samples which were seized on the door, or if there's a medical incident and people happen to still have something in the pocket that their mate took and caused a problem, or ground finds, things found on the dance floor. Basically, all of those things would be brought to our lab. We'd have a little mobile lab on site. We would test things as quickly as possible and get that information back to the medics so that can help with the treatment on site. Also to police and security, so they can keep an eye out if there are any things of particular concern to the management, and also get that message out to wider drug-taking communities and clubbers through our social media and our media, which has been really important, more important than we thought at the beginning. And some of our messages have got up to and over 500,000 viewers, so that can be a good way to get out messaging, very quickly. But also we have to be careful about that, and we're mindful we don't want to sort of cry wolf or be inaccurate in relation to that. So we did the very first testing in a UK nightclub in 2013, professional chemists, graduate chemists, to be doing the testing right from the beginning. I hauled in family and friends and favours. So the very first chemist was a good friend of mine, a PhD chemist, so I dragged him along. The very first equipment that we bought was FTIR, which very quickly in 60 seconds can identify most substances. And that was the first time that equipment had been used for that purpose. And I think probably because I'm a criminologist, I was able to be cheeky enough to think about using that equipment like that, and had quite a lot of criticism from chemists that it was inappropriate use of it. But now drug checking services around the world use that. It's probably the number one bit of equipment used by drug checking services around the world. So chemists test it, and then we have healthcare staff who interpret the test results for people who are going to be taking the drugs, to provide harm reduction advice and information. And I think that's the key thing. It's not a chemistry research project. We're testing to get the information to reduce harm, to communicate relative risk and to reduce harm. So that's the end goal in relation to this. We will have a public-facing service, and that was introduced in 2016. And for that, members of the public can bring a sample. They will drop it off in a sort of little lock box. They go away, come back an hour later, and then they will get their test results and have a healthcare intervention with one of the healthcare staff, where they will talk to them about their medical and drugs history, and then they give them the test result, and then they give them the sort of tailored harm reduction advice. about 85% of what people think they've bought is the case that they've bought it. And a lot of the messages are around appropriate dosage and risk of overdose, actually not about adulteration at all. But we asked for a very small amount of the substance. We never give anything back. That would be illegal. Technically, it would be supplying if we gave the drugs back to the person. There are some drug taking services around the world where they do give it back. In New Zealand, they do that. That's allowed. But in the UK, legally, we're not allowed to do that. So we take the substance off them, we test it, we do all sorts of different tests, destroy it in the testing process. We normally do about 4 or 5 different tests to find out as quickly as we can what the substance is. And then they have a number of choices. Do they want to take it? Do they want to hand it over? If it's not what they thought, about 2/3 of people will hand it over to us because they don't want to take it. If it is what they thought, that's where we talk about dosage and also heightened risk in terms of polydrug use. So, for example, a big one for us is about, if it's ketamine, the risk of combining that with alcohol, the most significantly increased risk. If it's MDMA, we might talk about the increased risk around overdose and high-strength pills, things like that. But if it was something that's really, particularly dangerous, a real serious substance of concern, with a wider public health messaging, that's when we would go out to an alert. So we will put out the alerts on our social media, and also public health groups will also put it out on theirs through their messaging services, early warning systems, locally, nationally, even internationally. Some of our alerts have been covered in the international press. So we can have, quite a big reach, really, if we deem that it's needed.
Hi, and welcome to Deep.
We love making videos, meeting people and letting them tell their stories.
We really hope you're enjoying the channel, and if you are and would like a bit more,
We've just launched the series as a podcast on Spotify.
It's the full interviews uncut, so you can hear the whole thing, wherever you are, at home or on the go.
But no matter where you're watching the content, please remember to like, comment and subscribe, as it really helps the channel.
And don't forget to drop a comment below and tell us who you'd like us to talk to next.
Thank you. Now, back to our story.
Okay, cool.
Nightlife is always changing, it's always in flux. That's part of the thing. I think one of the things that we've seen is that smaller pubs and clubs are closing, but in their place we're saying, much larger bars and much larger clubs. So we're seeing these, the vast capacity where my charity, The Loop, tests in the Warehouse Project, that's got 10,000 capacity. We test at Drum Sheds, that's got 15,000 capacity. And people are tending to go out less often, but they're looking for that big experience, the big Instagrammable experience. And so I think that's changing, and that's been quite tough on the smaller clubs, the smaller venues, that they've had to close, and that they're not having that sort of traffic in the week or the low key weekends. People still want the big weekends out once a month, but they're not in the intervening weeks going out as well. And I think that's the tough thing, and that's what's been changing. So the smaller promoters and the smaller DJs are finding it more difficult to get gigs in the wintertime in the UK. But yes, we've seen the festival scene massively expand. Festivals weren't really so much of a thing when I started doing research on nightlife. People might go to Reading or Leeds or something like that, but we've got hundreds of festivals now. Depending on how you define them, you could say in the UK we've got 300 or more festivals. And most people see festivals as part of their summer season, if you like, and will go to at least one or two. And if you talk to young people now, they all say that they prioritise going to a festival over a Mediterranean holiday with their friends. So whereas they might have gone to Ayia Napa or Ibiza with the mates, looking for, sun and, big clubs, the big sort of super clubs and all of that, is they will, 2/3 of them now will prioritise going to a UK festival despite the weather and despite the mud. And, along with that is that consumption patterns have changed. So we know that young people are drinking much less alcohol. Nearly half of young people are not drinking at all, or are drinking, more low alcohol drinks, as well as no alcohol drinks. And that market has expanded massively, really. And along with that, taking less drugs, or taking drugs less often. Again, it might be for those sort of special occasions. But we see that it's a mixed picture in relation to drugs. That for some drugs there's been a decline, but for others we're seeing them increase. So it's a complicated picture, but definitely that shift towards monthly or occasional experiences, the big experiences, as opposed to going out every weekend. I've been working in the field of drugs, drug use, drug trends, drug policy for 3 decades now. And I think for myself and colleagues that I work with, we're always trying to push for evidence-based policy. But drugs is an area that all of us who work in that field, whether politics or academia or practitioners, are often passionately committed to. And in all of our ways, we're concerned about the implications of it, but come to different conclusions in relation to that. And I think for academics, we'll push on evidence-based policy. And I've been a government drugs advisor, on and off since 2008. But we're also mindful that we're not democratically elected. And if you look at what the electorate wants, quite often they're more conservative with a small c in relation to that. I think generally there's a view that we want to shift from a criminal justice-based approach to a public health-based approach, because we all are concerned about the drug-related death rate. And anything we can do to reduce hospital admissions has got to be a good thing. But I think additionally to that, for me, I'm coming at it from a social justice perspective, a social equality perspective, and concerned that quite often the people who are most harshly impacted by drug laws are the people who are most vulnerable in society, multiple deprivation. The idea then is that drug policy can often be used as a tool, really, in terms of controlling certain groups. Traditionally, historically, looking back, we can see that drug policy all around the world really has been used to marginalise and control specific minority ethnic groups, being true in relation to controlling women, particularly around things like pregnancy and childbirth and child rearing. It's a way to keep certain people in their place. And so for me, drug policy can't be separated from social justice issues. And because of that, I think it's not just about public health. For me, drug policy is also about human rights. So I favour a human rights-based approach as opposed to simply moving the dial from criminal justice to public health. Both of those are important as well. But the third sort of leg of the picture for me is to bring in human rights as well. I think there's a lot we can learn from a lot of different countries. I wouldn't say that it's one in particular getting everything right. But one of the ones in Europe that's been held up has been Portugal, that they've had decriminalisation of personal possession of drugs for 25 years. And one of the benefits of that has been that all of the money that's been saved, which would have gone into law enforcement, can be diverted to public health, which has got to be a good thing. And particularly in the UK at the moment, we are desperately in need of more resources for public health. But then we still have the ambiguities around the fact that if you decriminalise use but not supply, you have a situation like in the Netherlands where you have cannabis cafes where people can buy cannabis from the front door, but they're still supporting organised crime groups by buying their cannabis from the illegal market through the back door. And then you still have the concerns around adulteration, contaminants. And, in terms of the countries that are not getting it right, the big concern in North America is synthetic opioids and the fentanyl crisis, which has been a public health emergency for years. And the knock-on effects of that for everyone in society, really, it's a horrific tragedy right across the board. Uruguay is interesting in terms of the legalisation of cannabis because they decided to have a state model, whereas in some areas and countries in the States, for example, with Colorado, they went down a model which was much more about a sort of free market model. The whole thing is this relationship between supply and demand. The demand is there. So how do you curtail the supply so it causes the least harm to the least number of people? So in Uruguay, it's about providing cheaper and low potency cannabis and pulling the plug out really from organised crime groups. The league's been going for 12 years. We now have got 5 Home Office licences. We've got a drug checking service that's regular in Bristol city centre, but we've got a lot to do still, and we're still really in the earliest stages of that. We hope by the end of this year that there'll be 6 drug checking services in the UK, 3 by the Loop and 3 by other service providers. But there's still a long way to having national provision, and that will be the ideal situation, that anybody can test anything before they take it to know what's in it, and for us to have much better understanding of what's in circulation in the market. It can make people more wary of buying off strangers, and that's got to be a good thing. That in terms of that people are more likely to be ripped off by strangers than their neighbourhood dealer, because with neighbourhood dealers there's an accountability. If you buy from a regular dealer and you have a negative experience, you go back and tell them off and get a refund. And the dealer themselves might not know what's in the supply. They might have been ripped off by somebody higher up the food chain. So I think one of the things is we're trying to get information back to people who might be thinking about taking drugs, but we're also trying to get information back up the food chain to the suppliers. And hopefully some of those might then bin the bad pills if they discover that actually they're not what they thought they were as well. And I have had a very small number of threats from dealers, but only a very, very small number. And what I would hope comes across is that, I'm passionate about supporting nightlife and, supporting people to be going out and do what they're going to do anyway, but trying to be communicating relative risk and reducing harm. So what I would hope is that we're not on opposite sides here. Most dealers don't want to kill their customers. I don't want them to kill the customers. I hope that we have got some aligned aims going on here. I went there, I talked about the specific way that I set up the Loop in the UK, this idea of bringing together professional chemists, health professionals, focusing on it being a university research project as well, an action research project. So to evaluate it, to keep making the case for the value of it, being aware that we're continually negotiating and making the case for it. And I still am here in the UK, even, this weekend I've been doing that. And so that it seemed to, strike a chord with some people in Australia. And I was there and we set it up in 3 states. And they've been drug checking in 3 states. And they had the first drug checking in an Australian state last year, and I was there for opening it, and that was in Brisbane. Drugs tend to be a lot more expensive there, maybe like up to 5 times more expensive, but also they have much more adulteration as well. So, for example, we've seen the synthetic opioids in their cocaine and ketamine and MDMA market there, which we haven't seen yet here, but I'm, sure that we will be, and that's just on the horizon. So I think they've got greater challenges around adulteration in Australasia. At the moment in the UK, our biggest challenge with MDMA is the high strength, whereas of the pills. Whereas in Australia, they have capsules. They don't really see so many pills. And the capsules, anyone can open them and put any powders in. So the opportunities for adulteration are much greater there in terms of their market. If people are taking illicit substances, they won't necessarily know what's in them. So if they can have access to drug checking services, to use those. If not, you can buy testing kits to use at home. If they're used carefully, they can be accurate, but people do have to follow the instructions quite carefully. If people don't have access to those, then to take small test lines or a quarter of a pill. Stay hydrated, that's always an important thing. People to pace themselves, not to go too hard too quickly. So we say go slow, stay low. And probably the most important thing is to look after your mates. Quite often when people come to harm, it's because they've lost touch with their friends in the crowds and things like that. And then by the time the medical and welfare staff get to them, it's too late. There's a somewhat corny harm reduction phrase, which is leave the mixing to the DJ. And there is definitely truth in that, because different drugs will mix in different ways. So generally the advice is not to be mixing any drugs together, but we accept also that people do. Polydrug use is a feature of a lot of people's weekends. So generally the suggestion will be, if people are going to do that, to leave a space between the different drugs and to be mindful of the sort of upper and downer combinations, which can be particularly complicated. And generally alcohol is not a good idea with any illicit drugs.